Now, we got some questions from you over the last 2 or 3 weeks, and I just didn't get a chance to answer them. Today, we want to make sure that we clean up some of the questions that came up. So, Cynara, maybe you can read the first one.
I will. Actually, most of these are directed towards you, Dave, which is great because it's good information for all of us. This is from Alex from New Jersey, and he says, I'm a 54-year-old male with elevated PSA. I've had multiple ultrasound biopsies of my prostate.
Yeah.
What is the role of the MRI fusion biopsy?
So, you know, when we're talking about a young man like this with an elevated PSA, a lot of times what happens is, you know, they get a biopsy and it's a random biopsy, and the cancer actually could be there, but it could be on the anterior part of the prostate, or the biopsy could easily miss this. Typically in our office, we used to use an ultrasound technology to do the biopsy. So the patient will come in, they have taken some antibiotics, I use the ultrasound machine, and we would take images, and maybe if we have an image of an ultrasound, you can see that over here when we're taking these cores of biopsy, the actual lesion could be an area where the needle could absolutely miss this. And so the patient goes through multiple of these biopsies. There's no cancer, he's happy, but the PSA continues to go up, and that's a huge problem. Recently, what has happened in our office, and we were one of the first centers in New York City that started using the images of MRI, which is really important. So patient will go in and get a 3 Tesla MRI, and we have some images to show you, where they would take the images of the MRI, and then we can see, there's another picture where it can show you the lesion on the MRI exactly where the cancer may be. And based on that, we can combine the images of ultrasound and the MRI. And for example, you look at this MRI image and you can see where the arrow is. That's a suspicious lesion that normally on ultrasound you don't see it. So on one side is the ultrasound, on the other side is the MRI. So our technology has really improved. Now what do? We take the images of the MRI, and the computer, the image that we just showed you is a picture of the MRI fusion machine, combines these images, and then you can see exactly where the target is. And now, you know, you do a targeted biopsy. Now, not every urologist has this. So when you go for your biopsy, you want to make sure that it's a real fused MRI biopsy. That's really important, because with ultrasound, you can miss this. And the other thing is that the old-fashioned ultrasound biopsy used to find a lot of low-risk prostate cancers, which that may or may not really kill you, and it would just, you know, make the patient very nervous. They would upset them. Oh, I have the cancer. Once they hear the C word, but there's different type of prostate cancer. As you know, there are some moderate risk, some aggressive ones. What this MRI shows is mostly moderate and aggressive prostate cancers, which is really need to be treated. So what I will tell Alex is that, of course, like, you know, there are a lot of great institutions in New Jersey. We're here in New York. Always is important to get a second opinion. You can bring in whatever biopsies you've had. Maybe you understand that it's negative, but you may have an atypical cell, or you may have something called high-grade PIN. Those are suspicious lesions that may or may not lead to prostate cancer. We would study all of that. We look at the trend of your PSA, and then I would get the MRI after the examination and decide what to do. So I think, you know, the other thing, Cynara, you've heard of something called 4K test. It's a special blood test that combines 4 different types of PSA. And there's also a urine test called PCA3. So we add all of these components, and then you make it's like a detective work. Should someone get more biopsies or not, etc. And that's how we'll do this.
Technology has changed so much for your field, and obviously for the benefit of the patients.
Isn't that the same also, like in your field of breast cancer? Aren't you guys using
imaging,
more MRIs?
Absolutely. Now we use MRIs almost routinely for patients, especially patients that have dense breast tissue or have a diagnosis of breast cancer. But I find, you know, for a similar reason with patients that come to my office, if I feel a mass, I may or may not go ahead and do that biopsy. I usually try not to do the biopsy initially. I rather either do it as an ultrasound-guided biopsy, or I will send them to a radiologist to have it done as an ultrasound-guided biopsy, because at least you can see the needle going into the mass, taking a sample, and coming back out. Whereas if you're doing it just on feel alone, which sometimes we're kind of forced into that situation to do it that way anyway, But when you're just doing it based on feel, you don't know where your needle is making
You
contact.
can miss it.
So the imaging is just so important, and it's so great to hear that so much has changed in prostate cancer diagnosis.
Well, what's interesting, and we've spoke about this, your field of breast cancer and our field of prostate cancer, they go parallel,
Yes.
hand in hand. Not only the numbers, but also the diagnostic tools are becoming more and more sophisticated. So ask your doctor, do you have an MRI fusion biopsy? Is that what you're going through, or any kind of biopsy? Let's go to the next question,
Okay.
Cynara.